introduce our speaker. He doesn't really need any introduction, but I promise his office I'll let him out of here at 9 promptly. So we'll finish a few minutes earlier so you can say hello. Our healthcare system is not perfect, but is one of the very best because it listens to its stakeholders, its physician leaders, its patients. So how do we best communicate with the system overall and influence its future? Here with us today is Dr. Bob Bell, who's going to take us through a discussion on the Ontario healthcare system. For those of you who are young and have never met the man himself, they have to be very young to not know who he is. Just to remind you, you're sitting in the Bob Bell Auditorium. Dr. Bell was appointed Deputy Minister of Health and Long-Term Care effective June 2014. Prior to this role, he served as the President and Chief Executive Officer of the University Health Network for 9 years. He was previously the Chief Operating Officer at Princess Margaret Hospital and Chair of both the Cancer Care Ontario's Clinical Council and the Cancer Quality Council of Ontario. He is, of course, a renowned physician and surgeon, an expert in the management of sarcoma. He got his doctorate, Doctor of Medicine, McGill University, and Master of Science from the University of Toronto, completing his fellowship in Orthopaedic Oncology at Massachusetts General at Harvard University. He is a Fellow of the Royal College of Physicians and Surgeons of Canada and American College of Surgeons, and an Honorary Fellow of the Royal College of Surgeons of Edinburgh. Dr. Bell.
Thank you. So I just had one of those kind of out-of-body moments. You know how it is when you're doing a few things and you never know quite where you're going to be, and it's kind of moment to moment. You grab your BlackBerry to find out where you're going, to remind yourself which floor is the auditorium on. I'm looking at my BlackBerry 6 floor, step out, I see, holy smoke, they put my name here? So, Paul, thank you. It was very, very cute. You know that story about Russian villages, Potemkin villages, the Tsars coming to visit, so you put fresh paint on it. I put my name on it. So, first of all, Dr. Waters, congratulations. Dr. Fishers, congratulations to you for recognizing us. And what I thought I'd do is I was going to come here and convince all the doctors in the room to vote yes on the ratification. And I see there aren't that many doctors, so I won't bore the rest of you with how rich Ontario doctors really are. What I would like to talk about, is the management of highly prevalent conditions in Ontario that we currently manage very poorly. And I want to talk about how we can improve that, and how the organization of the Ontario health system actually holds us back from treating some conditions well. What kinds of conditions am I talking about? Well, I'm an orthopedic surgeon by background. Back pain, neck pain are great examples. Headache is a great example. Those two conditions alone, because of the poor management of these highly prevalent conditions in Ontario, contribute to the fact that Ontario has one of the highest rates of opioid drug dependence in the world. Because we manage back pain poorly, a lot of folks get hooked on oxycodone during the course of management. That really is disjointed. It's not programmatic. I'll come back to it. One of the other things we've managed extremely poorly, the most highly prevalent condition, is end of life. I think we all know that. You know that from cancer. We do far better cancer end of life care than we did probably 10 years ago. But there are a number of conditions that we can recognize as being end of life conditions: chronic obstructive pulmonary disease, congestive heart failure, that because of the lack of a programmatic approach to care in our system, we spend an enormous amount of money providing care that really doesn't improve the well-being, or the end-of-life care of our patients. So we do some things extraordinarily well, and cancer care is one of the things. I think it's fair to say, Peter, having worked in several different environments, cancer care in Ontario for the entire population, a population-based approach to cancer care, it is very good. It's certainly a lot better than it was in 2001, 2002, when the Minister of Health of Ontario questioned whether or not cancer care in Ontario was doing such a bad job that it should be eliminated, finished. And I was, John Irish had some experience at that time, Bernie Cummings had some experience at that time, I had some experiences at that time, and I learned a tremendous amount from the redevelopment of the Ontario cancer system and progression toward what today is, I think, a very well-performing system, not just for some, but for anybody who gets cancer in this province. Not perfect, could be better, constantly needs improvement, constantly needs focus on quality improvement, but certainly, for the vast majority of Ontarians, far better than it was in 2002. So that's not that long ago, right? That's not that long ago. And what are the lessons learned from that experience and transformation of the cancer system that we can apply today, and indeed we are applying today, the transformation of the entire healthcare system to focus on highly prevalent conditions that are badly managed because there's not a programmatic approach to organization of services. I think we all agree that individual services in Ontario health system are pretty good. Silos of systems work reasonably well. However, the interconnection between systems to create programs of care that are multidisciplinary are a really important area of focus for us. And when we start out, I started this job 2 years ago, sort of thinking through, where do we need to go? It's something that I've thought about for a long time. How do we need to get a sustainable, cost-effective system that provides the kind of care that Ontarians are looking for? So, trying to do that, I had ideas, but one of the things I found in the Ministry of Health was a tremendous amount of data on what Ontarians think about the health system. And that's where this connection between what happened in 2002 and where we need to travel today really started to develop. When we look at what the Ministry of Health does, there's a huge amount of data on surveying Ontarians about what they think about the healthcare system. And each year, long-form telephone interviews are undertaken, about 20,000. And data is gathered. They're not exactly the same every year, but there are certainly trends that you can see that evolve. They're not, entirely representative. If you don't have a landline, they're not going to be included in this because most telephone surveys relate to landlines, although that's changing. But if you look at this wealth of data, what you see is that about 12, 15 years ago, as these surveys started, Ontarians had real concern about what I would term the acute care part of the healthcare system. There are stories about, well, you know this extremely well, people going to Rochester, people going to Buffalo for breast cancer radiation, stories about people on a long cardiac surgery wait list that, died waiting to get their triple bypasses done. Stories that really reflected for Ontarians a lack of confidence in what hospital care was providing. Stories about hospitals being closed for C. difficile outbreaks on a frequent basis. When you look at the progression, so 10 years ago, 12 years ago, concern about Ontario's hospitals, concern about, will my mother be able to get a total hip within 2 years after she needs that operation? These concerns about waiting lists for acute care. Fast forward to today, the last 2 or 3 years of information, what we're hearing is that there's relative confidence in the acute care system. Always concerned about wait lists. That's always going to be a concern in the publicly funded single-payer system. Wait lists will always be a constant problem that we've got to work at, got to analyze. But relative confidence that Ontario hospitals treat their patients well and serve the population well. But what we hear is we hear people say, I'm delighted that I have a family doctor. Because today, 95% of Ontarians have access to primary care through a primary care doc, through one of the various models, family health organizations, family health teams, family health groups. I won't bore you with differences in how much those make and money. I won't bore you with that. But, you know, most Ontarians have a primary care doc. Today, 95%. If you look back to the earlier surveys, 2002, you know, 70, 60%, depending on the population, where you are in the province, really, only about 2/3 of Ontarians had access to primary care. So today, people say, I'm delighted to have a primary care doc. You know, can't always get to see him when I need to see him. My daughter had an earache, and I phoned up, and they said, well, we give you an appointment with Dr. Smith for a week from now. I said, well, she's got an earache, she's got a fever. I said, okay, you can go to the emergency department, right? And if you look at international surveys of how this province, Canada, performs in terms of access to primary care, you know, we don't perform very well, right? You look at the Commonwealth Fund data, analysis of performance in 11 different Western nations. We're 10th out of 11. Americans do worse than us in terms of access to primary care. But if you ask Ontarians a simple question, can you see your doctor within 24 to 48 hours when you're sick? Only about 50% say yes. Now, a lot of people say, well, the Commonwealth Fund doesn't sample many people. We've done a lot of surveys on this. And it's true. I'd say about half of primary care providers in the province are providing access that's appropriate. About half aren't. If you ask the question of, do you ever have to go to the emergency department because you can't get access to your primary care provider? Same thing. We perform 10th out of 11. When we ask that question, citizens randomly across the province, we hear about 50% of primary care providers end up with their patients going to the emergency department because they can't get access. So access to structured primary care is a key area of focus. In my view, the literature certainly reflects that a solid, absolute foundation of primary care that's universal, accessible, understandable by the citizenry is probably the most important part of a high-performing health system. I would say today that we've got the human resources to achieve that. You know, we're bringing 900 net new doctors into Ontario annually, about half of whom are primary care docs. But we haven't organized the system in a way that ensures this solid foundation of access to primary care really exists. So that's problem number one. Problem number two, intersection of care in the home and community. So one of the most common problems I heard when I was in Dr. Pister's role were issues like, you know, I've got back pain, and I've been waiting for 6 months for an MRI scan. I got my MRI scan, and then I waited another 6 or 7 months to see a neurosurgeon. So I got to see the neurosurgeon a year after I started complaining about my back pain. And the neurosurgeon saw me for 15 minutes and said, I can't do anything for you. You don't need surgery. So it's a year, and I still don't have an answer. We also hear from folks who say, you know, my son, my daughter, 14-year-old, was experiencing behavioral issues. I was worried about drug addiction. I was worried about their variety of issues, worried about their behavior. You know, it took me a long time to figure out how to access care for them. I eventually found care, but I had to navigate the system myself. Talk to my neighbors. My primary care provider wasn't really very helpful. I've heard people say that, you know, my mother lives in this part of the province, needed access to home care. And we couldn't figure it out. It took forever. Whereas my sister's mother-in-law, who lived in a different part of the province, got immediate access to home care, and they brought a personal support worker in to see her 7 or 8 times a week. And there's huge difference. They seem to have about the same huge differences in care across the province. So the organization of care in the cancer system is pretty good. You know, you look at the wait times for access to cancer care. You look at the time it takes for women with abnormal mammogram to get to their diagnosis. It's not perfect. It needs work. But we've got data on it. We know where we need quality improvement. We can measure patient experience, and we look at outcomes. If we move away from the formal cancer system, the formal cardiac system, we move into the home and community care, primary care part of the Ontario system. We've got very little data. We've got terrible integration of services. And we've got a system that's just really really hard to navigate. So that's the next problem on our problem set that, we started thinking about a couple of years ago. The third big problem relates to equity of access. Like, we know that for Ontarians, Canadians, healthcare isn't just about healthcare. Healthcare is part of the social fabric that defines who we are and how we think about each other. And one of the conceits we have, one of the falsehoods that we believe in, is that the healthcare system is equitable in providing access. We think that access is dependent on need rather than ability to pay. But if you look at healthcare resources across this province, and if you look at the prevalence of chronic diseases, one of the most important elements that determines both of those is the mean annual income of the postal code of the people that you're looking at and the resources being located in. We know that if you're in a poor area of the province, if you don't have if you've got a lower than mean annual income, you're going to have a higher risk of having congestive heart failure, higher chance of smoking, of being obese, higher chance of having diabetes, chronic diseases that require healthcare investment, we know are higher prevalence in areas of lower income. So it makes sense, if that's the case, that if you do a heat map of resources across the province mapped against income, you should see a greater availability of healthcare resources in postal codes that have lower income, right? That would reflect our conceit that access to healthcare resources in Canada is determined by need rather than ability to pay. And of course, if you really look at that heat map, you see exactly the opposite. Higher income, in Rosedale, you got more doctors, more pharmacists, more private physiotherapy clinics, more access to hospitals than you do in areas that are not wealthy, not advantaged. So, the biggest example of that, if you look at northwestern Ontario, taking on this job, visiting some of our Indigenous communities, it's quite striking how we don't have equal access to even basic health care in the province. So that's the further problem set. Now, if we look at those issues together, access to primary care, either physician primary care or nurse practitioner primary care, there are a wide variety of models, many of which are working extremely well. If we look at the issue of integration of services in home and community care, and if we look at the issue of equitable access to healthcare services in the province, depending on need, the first question you ask is the same question that we asked back in 2002. You ask yourself, who's in charge? Who's in charge? Who's supposed to integrate these services? Who's supposed to ensure that highly prevalent conditions being poorly managed are actually managed through a programmatic approach? It says, if you got back pain, you don't really need to wait 7 months for an MRI, and another, problem is really manageable in 95% of people by access to education and physiotherapy. Some education about exercise, how you manage chronic conditions. We're just not doing that in a programmatic way that makes that available for folks. So how do you deal with these things? First thing is to decide who's in charge. And that was the answer to the cancer system evolution that started back in 2002, 2003 was determining there need to be regional cancer centers, vice presidents of cancer care in each one of the regions of the province. Dr. Gospodarowicz is one of those now. Mary's in charge of outcomes, organization of cancer service. I can't think of anybody better to be in charge of anything than Mary. But, in charge, right? Not just at Princess Margaret Hospital, not just at UHN, not just at Mount Sinai, but at St. Joseph's Hospital. You need to understand who's accountable. Second thing is you need to have data. You need to have data that demonstrates what the problem is, how bad it is in the region that you're looking to improve, and some milestones that anticipate improvement. So, that answer to that primary problem, really in Ontario, needs to be the LHINs are in charge. The boards of the local health integration networks, the word in their title, integration, integrating care, developing programmatic care, surely the local health integration networks need to be in charge. And whoever the CEO of the LHIN is needs to be accountable for integration and improvement of programmatic care, especially not in the hospitals. if you look at the progress and the quality improvement in hospitals, it's been achieved under the Excellent Care for All Act that Minister Matthews introduced back in 2006, 2007. Been huge, huge improvement of measurement of quality. Dr. Pisters is absolutely accountable to his board for the quality of care. When I started my role, that wasn't very clear. But it's very clear that there's somebody in charge of quality of care within the 4 walls of the University Health Network, or the 24 walls. I don't know how many walls there are. 32 walls that define it. But, you know, the concept of this same accountability for integration, for improving patient experience across home and community, across primary care. Well, with the introduction of the Patients First Act, just before the House rose in July, and the anticipation that it will pass, this introduces a new model of accountability for the Ontario health system, not just within hospitals, but within the entire region of services, primary care services, home and community services, an integration that speaks to the patient experience and the navigation of what are often excellent siloed services that don't interconnect well for the complex, prevalent conditions that we know Ontarians aren't managed well for. So, LHIN's in charge. But, you know, if you look at our 14 LHINs, you can't really organize. If you look at the central LHIN that goes from North York, the 401, up to South Lake Simcoe, or you look at the Central East LHIN where they're proud to say, we go from Victoria Park to Algonquin Park. You know, it's hard to think that you can get an integrated system across those kind of geographies, right? And Central LHIN, you know, 1.8 million people. So that CEO, Kim Baker, the CEO of the Central LHIN, needs to be in charge of the integration of services, developing methods of modeling, improving services, measuring the impact, needs to be in charge of achieving the milestones that we'd expect. But to do that, you really have to break the LHINs down. So the second thing is to create manageable referral areas that we're calling, for the want of a better term, LHIN sub-regions. They're based upon the geography of health links, essentially. Health links being developed 5-6 years ago to deal with complex patients. That geography now building out to serve not just complex patients, but to provide integration of services for all patients. If you're going to have one board in charge, classic governance, this hospital, Dr. Pisters, reports to a board. Board decides with every meeting, really only one question. Is Pisters doing his job? We listen to a variety of inputs. My wife always used to say when I came home from the board, are you fired? Peter's wife's in town, now she'll start asking him the same question. So, you know, that issue of governance, you know, the LHIN board is accountable for 1.8 million people. It needs to break down the province into smaller regions. So we're anticipating the development of about 70 to 80 LHIN sub-regions, all responding to the LHIN CEO in terms of their performance. We're anticipating something else that we learned from the cancer evolution in Ontario. You need to engage clinicians. If you don't have clinicians at the table and patients at the table, because that's the thing we've learned subsequent to the evolution of the cancer system, you need to have clinicians, you need to have patients for advice. Within these sub-regions, we anticipate having primary care lead physicians, and we anticipate having directors and a small team of folks who are responsible for developing integration of services in these LHIN sub-regions. So you look at, you know, an example here, might be something like Flemington Park, right? Where right now, Flemington Park, everybody know what Flemington Park is? Got one of the highest pediatric, more children there than virtually anywhere in Canada. No pediatricians. No organized primary care. Largely served by walk-in clinics. So whoever the director of integrated care is for the region, the LHIN sub-region that involves Flemington Park, you know, we need to get some organized primary care there. We need to make sure we've got pediatric linkages. We need to make sure that we've got mental health and addiction services for children and adolescents. These kind of really basic questions we need to have answers for. We need to be planning within these LINS subregions for highly prevalent conditions. So if you've got a LINS subregion of 150,000 people, you can predict how many people in this region are likely to have new onset of back pain. And you can put in place those diagnostic services. Don't need MRI. You need a primary care physician who understands back, neck, musculoskeletal pain, who's had a short course in that, who works within an interdisciplinary team environment where we've got physiotherapists, we've got kinesiologists, we've got patient educators who can talk about the exercise goals, who can talk about the education that can manage most folks with back pain. And actually, your organization, UHN, has developed a model for that. It's called Isaac. It's now present in Thunder Bay, Hamilton, Toronto, starting in Ottawa. Very successful. It's dramatically reduced the number of referrals for MRIs, dramatically reduced the number of unnecessary referrals to surgeons, and surgeons don't need to see most of these patients. And most importantly, shorten the time off work and that markedly decrease the number of patients that require opioids. So we have evidence in the system that if we actually organize care in a programmatic way to deal with prevalent conditions, there are lots of models. Another example is mood disorders. The most common reason that Canadians are disabled and off work is depression or anxiety. And you know, there are some excellent studies in Canada that demonstrate you don't need drugs to treat that. There are lots of resources, cognitive behavioral therapy, other forms of structural psychotherapy, structured psychotherapy. I've learned this from Kathy Zahn. I know the words. Cognitive behavior, structured psychotherapy. These programs that really are cost-effective and effective aren't available to most Canadians. They're available if you've got good private health insurance. Most people don't have good private. You do. People in this room do. Most Ontarians don't. So making structured psychotherapy available for mood disorders works within about 6 to 7 weeks in 80% of patients. It's a very prevalent condition that has a huge impact on the Canadian economy and one that we don't have organized at all. What we do have is we have large numbers of GP psychotherapists, large numbers of psychiatrists who are providing psychotherapy to patients in unstructured ways that can go on for years and years and years with no evidence of outcome, no review of what the practice is. That brings me to the second point. That is that we need to have a way, the reason why this model of regional health organization is different from other models across the country is that it includes hospital boards. So most regional health authority models in the country, every other province but Ontario, when you move to a strong regional health authority model, you eliminate hospital boards so that the regional health authority can shift money, take money out of the hospital, put it into home care, that kind of an approach. That's not what we want to do because we're already very effective and efficient in our hospital sector. We have the lowest per capita costs with the exception of Quebec where labor rates are really much lower. Our hospital efficiency is the best in Canada. And our boards are doing a spectacular job of maintaining high quality services. We look at the quality of Ontario hospitals, they're as good as anywhere in the country. We want to have hospital boards continue, so that's one difference in this model. The second difference is physicians need to be engaged here. And we need to have the LINS, some authority, some ability to organize physician services. That's been highly controversial, and most of you are aware of the discussions that I have on a daily basis with the Ontario Medical Association. But, you know, they don't want LINS to be in charge. And, you know, the introduction to the Patient First Act, where we talked about the minister having the authority to require primary care to actually provide information about when office hours are open. Doesn't sound too bad. You know, that's been a real sticking point. And I respect that. I respect that. That's the job of the Medical Association. That's the job of physician groups is to negotiate. We negotiate. But there's no question that if we're going to have a strong system where services are connected, where navigation becomes more straightforward, we need to have a strong foundation of organized primary care in this province. It exists in Denmark, it exists in the Scandinavian countries, it exists in every country that has a high-performing health system. You know, we're not talking about less money, we're not talking about more work. We're simply talking about being accessible, and we're talking about groups of primary care doctors organizing themselves in such a way that patients can get telephone advice, you know, after 5 o'clock, and that services in the home and community are navigable, that primary care physicians have the information about navigation within the system. And that leads us to the issue of complex or community care access centers, CCACs, which you all work with that provide great service, great people working there, but disjointed from the rest of the system. If we're talking about who's in charge, we can't have two boards. We can't have a CCAC board and LIM board responsible for integration of services within a region. So part of Patients First is eliminating CCACs and migrating 6,000 clinical coordinators to employment under the LIMs. So why is that important? Well, right now, those coordinators are essentially, they're excellent people, nurses, social workers, really responsible for organizing and rationing home care. Not providing home care. Home care is provided, as you know, by St. Elizabeth, by VON, by health service providers who hire staff. 6,000 people in the province are responsible for basically contracting that care. Well, wouldn't it be better if those 6,000 people were in hospitals, as they often are today, in primary care, coordinating care in home and community across all home and community services? Wouldn't it be better if we had standard algorithms, modifiable algorithms, that said with this set of conditions, with this level of dementia, this degree of frailty, this is the kind of a home care protocol we should probably have? That kind of algorithm would free up a lot of time. So, bringing 6,000 coordinators into the healthcare system to work more generally, I think is going to be a huge help to ensure that that mom who has a 60-year-old with behavioral issues, not sure how to get services, mental health and addiction services in the community, let's have a coordinator can help organize that. So, bringing those 6,000 people under the lens to serve integration of the entire healthcare system is a large part of what Patients First is all about. You know, bringing those services together, bringing those excellent people, and they're excited about it, into coordinating the entire home and community system as opposed to a narrow slice of home care is what this is about. So, primary care organization within LIM subregions. You wanted me to be done, Rebecca? Well, I haven't talked for the next 4 hours. I want me to wrap up within 10 minutes. Is that fair? And then we can have a conversation. Okay. And then the final thing I want to talk about is equity, because you know I think this is a huge issue for us. It's a huge issue for us. You know, the way that Indigenous folks receive healthcare in Canada, most Indigenous people, is extraordinary. And I won't bore you with the details. Simply to say that if, you know, you go to Sandy Lake and you say, go to Attawapiskat and say, no, this can't be Canada. It's complex. It's complex. And, you know, the thing I didn't understand when I started this job was the impact on healthcare of the intergenerational trauma that does result from the residential school system. I sort of read about that. I sort of heard about it like we all do. I didn't know the last residential school in Ontario closed in 1996. Okay? And, you know, you look at the impact on intergenerational issues like parenting. You look at the incidence of chronic disease, the prevalence of chronic disease, you look at suicidality, you look at the impact of intergenerational despair combined with living circumstances in the most rural parts of the province, and you recognize here's a huge problem. Here's a huge problem that we simply need to solve. It can't remain out of sight any longer. And part of Patients First is to actually speak to Indigenous political leaders, healthcare leaders, about how we need to evolve that. And you know, at first you say, well, it's an impossible problem. But you know, if you listen to Indigenous folks, they got some great ideas about how the health system needs to evolve. Like they need to be they need a gallbladder operation. They need a gallbladder operation. But if they're dealing with mental health issues, if they're dealing with chronic disease issues, if they're dealing with parenting issues, we need to recognize the connection to traditional values and cultures that really our health care system hasn't been organized around. And this concept, represented by Aboriginal Health Access Centers, has really done some remarkable work. They're under the radar screen. ISIS has started to look at the outcomes that they're achieving. And it's with a blend of traditional methods of healing, respect for and reconnection with land-based values that Indigenous people. So we just have to think about a new healthcare system, not for doing gallbladders and heart disease, but something that deals with home and community issues in Indigenous communities, deals with mental health and addictions issues, deals with how young people are brought up in communities, deals with parenting advice in communities. That speaks to me to a different kind of home, community, and primary care in Indigenous communities. And so we're spending a lot of time during the development of Patients First. Most of Patients First has a timeline, it's got milestones. It's on a rapid course toward legislative approval and introduction, probably in the spring of 2017. The reform of Indigenous primary and home community care will take longer because it requires the conversation that is deeper conversation that reflects responsibility that Canadians have for creating the kind of social and health issues that you see when you go to San Diego. So that's an important piece of Patients First. The anticipation is everything I just told you. I'm in contempt of legislature. I love that term. I'm in contempt of legislature. I've assumed that the Patients First Act is going to pass. Bill 210 will pass. I expect it will. The Ontario Hospital Association's had some concerns about some of the issues. We're working those through. It's an essential piece of the tentative physician service agreement that we have with the OMA. Is that we've agreed, if you read the agreement, tentative agreement, we've agreed to amend certain parts of Bill 210 that reflect LHIN authority to demand information from primary care providers if the OMA will sit down and renegotiate primary care contracts with us. 75% of primary care in Ontario, undoubtedly progressing over the next 5 years to 100%, will be contracted care, not fee-for-service care. The vast majority of primary care income will be determined by contracts. The issue is, as usual, in moving it to an AFP, as everybody in this room working with an AFP knows, the key issue are the service level agreements, measuring those service levels, creating accountability. We haven't done a great job. Unlike the Oncology AFP, where I think we've done a pretty good job, primary care AFPs, we have not done a very good job of measuring accountability simply because it's hard to measure. It's hard to measure how well a primary care provider is providing access. So we need to put some work in place. We're going to be surveying Ontarians. This is another learning from the cancer revolution. I'm going to finish with where I started. One of the other learnings that we had, and John Irish has done so much great work this way, is by saying we have to measure. We have to measure things, and when we have information, we have to post it publicly. So we know from telephone surveys that about half of primary care groups in the province are providing excellent access. We know about half aren't. What we're going to do is we're going to survey about 2 million Ontarians every year. We're going to ask them, we know who their primary care is, they're rostered to Dr. Smith within the Greengrass Family Health Team. We're going to look and see what Dr. Smith's patients and what the Greengrass Family Health Team's patients say. Whether they have to go to emergency because they can't get hold of the office, whether the telephone is answered at 6 o'clock in the evening, whether they can see if their daughter has an earache and a fever, they can see Dr. Smith or one of his partners within 24 to 48 hours. We'll put that information up. We'll also put the information up for the Blue Sky Family Health Team. Undoubtedly, we know there's going to be Greengrass here, Blue Sky there, in many communities across the province. One of the best things we learned from the cancer experience with respect to quality improvement is you publicly post data, and there are discrepancies in performance. It has a huge, huge impact. So I got confidence that with renegotiation of primary care contracts to introduce some measures of accountability I won't bore you with, and with surveying Ontarians to figure out how well primary care is doing, we're going to see an improvement in performance. Because again, what I keep on saying to my colleagues in the OMA is, we don't have a strong foundation of primary care. Primary care providers who know through their coordinators, the 6,000 people we're moving over to service coordinators, who know how to get access to mental health and addictions for 16-year-olds with behavioral issues. They don't know where the ISAC program is that provides access to programmatic care for back pain rather than a 6-month wait list for an MRI and a 6-month wait list for a neurosurgeon who's not going to help them. Crucially, if we don't have a programmatic approach to the most prevalent condition that's poorly managed in Ontario, and that's dying, then we simply can't have a sustainable system. So, you know, I don't think we need more money for palliative care in the province. I think we need to recognize that a congestive heart failure patient who's been admitted to the Toronto General Emergency Department 4 times in the last 6 months is probably a palliative care patient. And we need to programmatically recognize that proactively and bring the treatment resources around that patient through recognition of where they sit. The Athena model, you know, recognizing those people, or simply reading our ADT feeds in a little more rational way as a starting point. We've got lots of ways of redefining programmatic care that will take the resources that we currently have, apply them more rationally to highly prevalent conditions that are currently being poorly managed, and really piss Ontarians off. You know, there's nothing that dissatisfies an Ontarian more than waiting a year to find out that they don't need surgery for their back pain. That really angers people. And when at the end of that year, they're addicted to oxycodone, you know, that's a human tragedy that we're promoting through disorganized delivery of services. So it's really exciting. That's what I've been doing with my last 2 years. It's been fun, you know. If you ask me what I've learned, so I'm finished talking about it. Somebody's going to ask me, what's your key learning? Yeah. Democracy is really inefficient. It's a really good system of government, but it's really inefficient. And what I just told you, is there anybody in the room who doesn't get what I just said? Is there anybody in the room that wouldn't have said 2 years ago if I said this to you? Yeah, just what Mary would have said? Do it, right? The last 2 years, I have been talking to innumerable people whose age, they could be in the Olympic pool. Their age range is 22 to 28. They work in government, they work in politics, highly committed, highly devoted. They know absolutely nothing about the healthcare system. And you got to convince each and every one of them. Before, but anyway, I'm overreacting. I'm not suggesting that dictatorship. That's one thing. The other thing I learned, and Marty knows this, Peter knows this, the people who work in the Ministry of Health are magnificent people, really intelligent people, really committed to the public good, a little bit risk averse. That's because they get beaten up if they make a mistake, but really committed to this. So thanks for the invitation, Rebecca. I appreciate it. Thanks, Kiki, for having these great rounds. I know how important these rounds have been in the lifeblood of PMH. Yeah. Thank you, and it's been a pleasure.
Great. The intent audience, I'm sure there are lots of points that you want to discuss. Any questions from the audience? Vicky?
So excellent talk, Bob. Always impressive. So as an academic health sciences organization, what do you think would be some of the top things that we could develop that would help the system? And you talked about the ISAC model, right? And so any other kinds of suggestions like that?
Well, the first thing is, how do you commit the resources, the huge resources, the University Health Network and the other academic health science centers? And Peter's been a leader in this. This LIN, under Susan Fitzpatrick's leadership, I think is actually leading the charge in terms of how this is going to work. And, so first of all, from the perspective of a hospital in general, community resources, most of this is about community resources. And hospitals aren't well trusted by community resources. Folks working in the community think hospitals want to control everything, steal their budgets, etc. Partly true. Hospitals do want to control everything. But, leaders like Peter are sophisticated to know you got to lead from behind. The thought leadership here, the IT leadership here, the financial leadership here, the organizational, the creativity that stems from being an academic health science center needs to be put behind this sea change in the way we organize. So, leadership outside the walls of UHN, Dr. Pisters embodies that, Dr. McClellan, the Sunnybrook, Dr. Howard, the St. Mike's. So quietly, the hospitals of Toronto are organizing themselves to be leaders of this. That's probably the first thing. The second thing is this desperately. The other learning from the cancer experience is anytime you make change, you got to evaluate it. So we're looking for evaluation partners, mainly ISIS, to help us look at administrative data that shows whether or not this is successful, to chart milestones, be doing that evaluation continuously. So those are two big areas where academic health science. Third thing is the statement that we all know. I mean, wonderful generation, Dr. Waters' leadership, the generation of new information from UHN will continue, will accelerate, but, we only apply what we know to be effective today to the treatment of every Ontarian. So that implementation science aspect that's become part of the the academic life of UHN, implementation science, measurement of health service outcomes, that's a crucial piece as well, and we need help.
Well,
There.
so, cancer system is good, we've all witnessed how it evolved, but one of the sort of, to me, absence in the system is the lack of R&D. So Cancer Care Ontario implements, sets standards, and counts on other people to develop the new models, and then they will test it. And the same with Ministry of Health. So the healthcare industry doesn't have an R&D component. It stays somewhere else. So following on Fifi's questions, how is Ministry of Health recognized and engages academia to further the improvement in healthcare system? Because it seems to be totally different system. Here is academia, and here is the healthcare system.
So that used to be true. And we've refocused through the Strategy for Patient-Oriented Research, federal initiatives, pump some money into ministries for research. We focused most of that money at ISIS. And ISIS is now very good at taking a question from us and turning it around. So recently, when we sat down with the OMA and said, on an evidence basis, how much should the healthcare budget for doctor services in Ontario? Very good academic question with real-world impact. How much should the healthcare budget for doctors of Ontario increase every year based on population growth and aging of the population? They had the answer back to us in 10 days, satisfied both the OMA and us. So those kind of questions. Another question is, how much does dementia cost, and how does it cost the healthcare system? So these are the kind of questions that we're interested in, doing research on the administrative data that we produce and looking at the interventions being provided. That's the short answer. It's obviously a deeper answer to your system, but the investment in ISIS has been a big part of that. And they're now much more ready to turn things around quickly.
I think there's a question back there.
Please.
Hi, thanks, Dr. Bell. I'm actually in primary care. I don't know if anybody else is family medicine here.
Do you agree with what I said?
In many ways, you're very excellent speaker. My husband, who's a physicist, reminded me on the way in, it is the Bob Bell Auditorium. So I'm in primary care, and I'm in a FO. So FO, for people who don't know, means we're capitated, so we get paid per patient that we have. And I absolutely agree, there are some doctors who have 5,000 patients rostered to them, and they don't take care of them. Which means that they get paid for every patient they have, but the patient calls, tries to get an appointment, can't be seen.
Very few with 5,000, but some with 2,500.
There are some, maybe 3,000. I have about 800 to my roster.
Yeah.
And I work part-time.
1,200 is the average number, 12 to 13 within the flows.
Should be.
Yeah.
So my question is about, well, I have a few actually, but accountability and the surveys. Because
Yes.
I have 4 slots a day for same-day appointments, often go unused. And I hear my secretary say, "Do you want? Oh, ear infection. Okay, how about 10:30? How about 11? No, not convenient, not convenient." I have an after-hours clinic from 5 to 8, of which I manage. Also, not full. We have this phone system, which is not efficient. They have to call a number, which tells them where the clinic is that night. So I said, you know what? Let me start up a website. People can just go Google it on my expense. I've done that. Still, people are not using it. And the reason they're not using it is it's not convenient at that moment. And that's the reality. Now, that might not be the most, but when you talk about surveys, you ask a patient, could you see your doctor? No, I couldn't. And you can. You actually can. You just can't see it at that moment. Now, if I see you, and of course I'll see emergencies, real emergencies, even someone who has depression and suicidal, I'll bump my whole day for them. But the reality is people have lives to live, and if they want to see their doctor on time for their regular appointments, they can't be seen when they want to be seen at that second. Because that means every time I see them, they'll get bumped, right, for their regular appointment. So people appreciate that. But I also work at the walk-in clinic in my area. I do 1 week a day there. And I see people from my FO all the time just coming in. Some of my own patients have come in. And I ask them, why do you come? And we explain it's not good care for you. You know, I happen to know you. I happen to be a little slower than most walk-in doctors. I'm a little more thorough, which means I get paid a little less. But I also don't send my reports to, it doesn't like anything I order.
Comprehensive care.
Exactly. But patients, it's not convenient for them. And they'll say, well, I didn't know about it. Okay, here's the information. Well, I called, it's not
So can I interrupt you?
Yes.
Because you're talking about 2 things. And
I'm talking about patient accountability now.
So 2 things. One, and you've seen the tentative agreement, speaks to patient accountability. It's work that the OMA, so it's work the OMA and the ministry need to do together.
Yeah.
All right? Because Ontarians need to understand how the health system works if we're going to have a sustainable system. Now, 3 things that I hear from your comments. The second thing is I hear survey data. And what I'm going to say is in the city of Toronto, where you probably work, you know, the conditions are equal for all the folks in the city of Toronto. And I know, because I've seen some of the early data, vast differences. All right, vast differences. I guarantee you, from the way you're talking, you're in a good performing folk.
Yeah. Like we're not in the negative for outside use.
So I don't want you to change your practice at all. I want your patients to understand that they've got those 4 slots of accessibility, and we need to figure out together a better way to make that accessible.
But they do understand, because we're a very aggressive
So let me tell you one other thing that we need to do. The city of Toronto, other urban areas where we're getting too many doctors. We need to start thinking together, OMA, ministry, about what represents high-value expenditure patient care dollars by doctors. Is a walk-in clinic a good place?
No.
I agree. Why are we paying walk-in clinics fee-for-service rates the same as what you would get in your office? In fact, little bonuses extra. You know that. You know, so I won't tell you what I think about walk-in clinics, but I think you can get it. That walk-in clinics. So here's where we're going. We're saying to the doctors in your sublink, the primary care leads are going to have conversations that are going to say, how are we going to organize ourselves? Because patients also want different kinds of opportunities for access. It may be that your group, a bunch of you, come together and say, we want to offer a walk-in facility for patients as part of our access model. Great. Access to records, return of reports, etc. I love that. That's part of your care model. I don't like the idea of paying physicians for rostered care and then paying again when their patients go to walk-in clinics. I know you get negated. I know your access bonus goes down. It's inefficient. We simply need to organize these services.
When you talk about education to patients,
yes.
We all do it.
Yes.
Governments will never penalize patients because it's not politically acceptable.
Well, we're not going to increase their income tax.
When we talk about Denmark and all these things, these are doctors, like, I'm all for being an employee, but when you're treated like
don't want you to be an employee.
I'm happy to be an employee. You pay my...
Stop this particular conversation.
Okay, can I just have one thing about the lens? The lens would be very helpful.
We have 2 other comments, and then
For the lens, though, just one thing about accountability.
Excuse me, Jonathan, you have a question?
Well,
Jonathan, you've given up your primary care practice.
conversation, I think there's more to it. But anyway, the bottom line is...
There's about 3 months more to it.
So, integration in informatics, and not just being able to view a CT scan done in another hospital or an MRI scan. I'm really talking about informatics across the entire system.
Yeah.
And not using administrative data.
Yeah.
I mean,
patient care data, point
real
of care.
data and real outcomes.
Yeah.
I know our UHN vision, but what's the vision across the province? Because really, in order to manage the system, you use the expression, how can you manage something you don't know how it's performing? And even administrative data doesn't really give us that value. So what's the vision across the province?
Yeah, well, I think it starts off with something that actually developed here. And PRO is an outgrowth of your leadership of surgical oncology, saying you're going to make a reasonable decision, you need to have sources of information available to you. So that concept of integrating all sources of hospital information systems, Ontario lab system data, the diagnostic imaging repository data at point of care. I would say in about 2 years, we'll be finished that journey. So CGTA, which doesn't work very well at UHN, will work.
Your conference is scheduled to end in 2 minutes.
Yes, that's something about CGTA. It will work better here. It's working well at Sunnybrook and other places. So that's one thing. We've got to add more data to that integrated system of data sharing. We'll start adding drugs to that from the Ontario Drug Plan in the fall of this year in Guelph. Over the next 2 years, all publicly funded drugs, all narcotics, and probably all privately funded drugs. So our entire pharmaceutical payment database will be on CGTA. For primary care providers, all immunization data in Panorama will be there. You'll be able to download information. Consumer digital health, first product being e-yellow card. So how many people have yellow cards? How many people have 7 yellow cards? Wouldn't you love to have one digital yellow card? So, so we're with you. The secondary use of that data, the issue of looking at that to determine. And for me, the cut point is, can we determine, if we look at all the population of patients we're caring from, can we make secondary use of the data we're gathering to determine when somebody's changing from being a standard care patient to being a more complex care patient, becoming a palliative care patient? And the answer is yeah, we can today. We can. So we've got to look at the secondary uses of that data. But the primary goal today is to make excellent integrated information available at point of care. That's number one. And secondly, to turn a more consumer focus onto the digital.
Your conference is now over. Goodbye.
To make it more digitally accessible to consumers, the web portals for your information, to start that journey. Those are the 2 things we're trying to do. The big issue will be, how do we get all the information on EMRs into the connected backbone? And I'm increasingly convinced that it'd be a mistake to try and get EMR data into the connected backbones. Then we need some information from problem lists from primary care offices into the connected backbone. We need allergy information, drug information we won't need because we'll put that in centrally. But a structured set of information from primary care into the connected system. That's pretty much the strategy for the next 2 or 3 years. The other strategy is a total relook at the way that we invest in hospital information systems. Because the system could easily spend $4 billion over the next 10 years with about 70 hospitals looking to renew their hospital information systems. So a letter that came to Peter and others last week saying the advice of our hospital information system renewal group that's advising us is we start looking at hubs where hospitals will provide information services through co-tenancy, one-instance models that serve multiple providers. And we got some examples of that are starting. I think that could save us easily 50% of the investment costs in hospital information systems. So that's a strategy that's got to play out with patients first.
Okay, last comment.
Dr. Pister.
Okay. Bob, you noticed that we have your name on the auditorium?
I did.
As you walked into the building, you may have noticed some scaffolding on the side of the building. That is designed to put your name up there. Now, my question really relates to what you've learned really interfacing with politicians.
Yeah.
And that, one of the interesting things that I noticed coming back to Canada, and you alluded to it, is that in the community of developed nations, we're number 10 in terms of the performance of our healthcare system. The average Canadian doesn't appreciate that and thinks we're already on the podium in Olympic speak. And it's very clear that in Canada, you can't win an election on healthcare, but you can certainly lose one. So how can we work with our politicians to set aspirational goals, to allow politicians to feel comfortable saying, we shouldn't be number 10. We need to be one of the top 3 health systems in the world?
That's a great question, Peter. The last 2 provincial elections, there hasn't been a word said in the leaders' debate. There hasn't been much in the platforms about healthcare. It's been a little bit under the radar screen. This election in spring of 2018 will be different, right? You see Mr. Brown, you can see Ms. Horvath lining up the issues about investments that the Liberals are not making because they've wasted money on gas plants, et cetera. So you can see that this is going to be a key platform. That's really good for us. Really good for us. Because building the government's platform in terms of investments in a variety of places. So for me, we were down at the Ontario Hospital Association. The minister spoke to me yesterday, said that his 2 key priorities are to get base investments back in the hospital investment cycle and deal with ALC issues through system capacity. So that's going to be a real focus for us. And I think this election, building that platform for the government, which has to be at least a minimum base for the opposition. I don't know who's going to win. I'm not a political person, but if we can build a platform that will serve as a base, the opposition parties have to, they're going to focus on healthcare. They have to go, but this will be a good election.
I mean, part of what we have to help them to grasp is that rational fiscal policy is predicated on rational health policy. And we're exposed to massive tail risk that has to be managed effectively through health policy.
So 42% of our budget, program budget, is in healthcare. If you look at the demographics of the population and you say, what's the impact of the aging population? Well, if you just do a straight line measurement, Peter knows this, of need for long-term care homes based on today's patient population. We need right now, we have 75,000 long-term care homes. We need another 190,000 in the next 10 years. Well, we can't do that. We clearly can't do that, so health policy has to help us solve that risk, solve that, currently a tail risk very soon.